Hello and good morning, afternoon, or evening to you all. I'm Urvita and I'm very pleased to be here today. Along with my colleagues Praveen and Yashi, in this lecture we will illustrate the rationale for as well as steps that are involved in the adaptation of a widely used implementation science framework for scale up. Through two distinct yet moderately similar case studies, we hope to show you how the REAM framework has been used in the context of care for a range of non communicable diseases, including hypertension, diabetes, and depression.
Hi everyone. We now explore the application of REAM framework in a non-communicable disease context by using ITREC program as an example. ITREC is an acronym of Integrated Tracking, Referral, and Electronic Decision Support and Care Coordination Program. The program was implemented in a rural district in Punjab, India. The ITREC program combined multiple evidence-based intervention. It is a complex scale-up program which used multiple evidence-based interventions for the management of hypertension and diabetes among adults across the hierarchy of Indian public health care facilities. The intervention components were an electronic case record form to consolidate and track patient informations and referrals, and electronic clinical decision support to assist clinicians to provide guidelines-based care, a revised workflow to ensure coordinated care across the healthcare facilities, and a training program for physicians and nurse care coordinators on evidence-based hypertension and diabetes management. Those who are unfamiliar with the Indian public healthcare system, it operates as a four-tier system at a district level with village level sub-centers and primary health centers, community health centers, and a district hospital, which act as the top level facility in the hierarchy. So India has a national program for the prevention and control of non-communicable diseases. Under the program, there is screening of hypertension and diabetes happens there at the subcenter level. There are basic curative services, including diabetes and hypertension management, available there at the primary health centers. A dedicated NCD clinic, which is there at the community health facilities, and advanced care for these conditions available there at the district hospitals. Theoretically, there is a referral mechanism which is there in place, but in practically, the referral care pathway is not either effectively implemented or not cohesively practiced. So the ITREC program intervention was implemented at all the levels of the health system with a tablet-based application for screening and referral prompts there at the subcenters, the tablet-based application and a clinical decision support there at the primary health centers and community health centers. And there is a systematic up referrals from the lower level facility to the upper level facilities and down referrals from the upper level facilities assisted by a robust IT platform. The intervention was delivered by clinicians and nurse care coordinators. They were assisted by a clinical decision support system. The intervention agents, that are the clinical physicians and care coordinators, were also trained as part of the program on evidence-based hypertension and diabetes management. The ITREC program used REAM framework in every level. That is the design, implementation, and evaluation of the program. The philosophy of the program was following the 5 domains of REAM framework. That is, an impactful program must reach the desired target population. In this case, the target population is individuals with hypertension and diabetes in the community. The second thing was the program should be effective only if it improves the health outcomes of interest. In ITREC scenario, the health outcome was early identification of hypertension and diabetes, and also the control of hypertension and diabetes in the community. The program should be adopted by the intervention agents, that is the physicians and nurse care coordinators. All the components of the intervention should be implemented well. That means the IT infrastructure should work properly. The up referrals and the down referrals should be seamless and should be working effectively. And the program component should be maintained and adopted by the relevant stakeholders even after the project period. The investigators also came up with a set of indicators by following the REIM domains. For the REACH component, the key indicators were the proportion of adults in the community screened for hypertension and diabetes, and the number of patients who are seeking care for hypertension and diabetes at each level of the facility. The effectiveness dimensions were predominantly quantitative in nature, with reduction in mean blood glucose and mean blood pressure levels there in the community and also at the health facility level. To evaluate the reduction of these parameters in the community level, the program also had a pre and post community-based survey. The other effectiveness parameters were the control of blood pressure and glucose among those who are already diagnosed with conditions and who were seeking care at the healthcare facilities. The adoption indicators were proportion of healthcare providers who log onto the NCD portal and the proportion of clinicians who fully or partially accept the CDSS prompts. A set of implementation indicators were also there. There were the percentage of hypertension patients who receive guidelines-based care, the percentage of the patients who were referred from a lower level facility to a higher level facility, the percent of the patients who made multiple visits to the healthcare facility, and the mean time of data upload at each level of facility to the central server. The maintenance dimension of the REIM framework was assessed by a qualitative survey conducted among the relevant stakeholders. So the REIM framework acted as a backbone for the implementation of the ITREC program. The data collection was streamlined as many of the indicators were inherently part of the intervention. For instance, the ESCRF, that is electronic case record form, and the clinical decision support system automatically captured data that was then used to evaluate the care continuity. Additionally, as I mentioned earlier, there is a pre and post cross-sectional surveys were conducted to assess the community level change in the hypertension and diabetes level. While REIM framework guided the program's design, implementation, and evaluation, at the time of evaluation, the investigators realized that certain domains like reach and adoptions were influenced by factors outside the intervention. For example, factors like socioeconomic status, the personal attributes, as well as health system factors like availability of medications and diagnosis tests influences the reach and the adoption rate of the intervention. To account for these influences, one may consider using theoretical models like Anderson models to better understand the determinants of the health-seeking behavior, where REIM framework had a limitation. So in real-world settings, it is common to adapt theoretical frameworks. For example, a framework like REIM can be modified to include dimensions such as health equity. So such adaptations can lead to new models that address different contexts or focus areas. And with extensive testing, these can eventually become a new theoretical model. So as implementation science researchers, we should understand the differences between an adapted theoretical model or a framework and a new theoretical model or a framework which you eventually come up after adapting these models extensively. So if, for example, um, if the fundamental principles and structure of the original TMF remain intact, even with the significant modifications to account for the context and the scale of the intervention, it can still be considered as an adaptation of the original framework. And in construct to address gaps in the original framework, as I mentioned earlier, for example, for REAIM framework adapted to include health equity dimensions might still be a REAIM framework. So when an adaptation lead to a framework designed for a distinctively different focus, that means moving away from an individual level adoption to a system-wide transformation, it may transcend adaptation and qualify as a new TMF. Finally, an adapted TMF that undergoes extensive testing and validation in different contexts will eventually become a new theoretical model or a framework. So the key takeaway is that while theoretical models and frameworks provide valuable guidance in the initial planning phase of the program, they should always be adapted contextually to suit specific needs and circumstances of your intervention. Thank you.
Hello again. In this part of the presentation, Yashi and I will be introducing you to our second case study, which is a randomized controlled trial of a community based mental health intervention to support individuals who are affected by depression. As way of context, this is an ongoing trial situated in Goa, a small state in the west coast of India. The implementation evaluation component of our trial is based on the REAIM framework, a framework which you now have become more familiar with. A few notable features about our project/trial which would be useful for you to know before we go on to introducing how we've used the REAIM framework is that one, our trial is a hybrid type 2 effectiveness implementation cluster randomized control trial, where we're basically simultaneously testing the effectiveness as well as the implementation of the interventions. To give you more context about the interventions, the first arm is a facility only arm, where we are delivering a psychological intervention for depression to patients who are screened in primary healthcare services. The second arm is a community arm, where we're delivering the same intervention but supplementing it with a community intervention which has two aims. One is to increase demand for depression treatment, and two, to increase adherence to treatment. Hence, we are assessing as well as comparing the clinical as well as the health system's impact that the intervention has. I specifically want to pause over here to reiterate that the integration of these interventions is in primary care and in community based settings. So, given that we were integrating this intervention into routine practice, there was a strong need for a framework for evaluation which was not only feasible to use but also logical, easy to understand, and potentially scalable for further use in our context. I'll now introduce why we felt that the REAIM framework was the appropriate framework for our program. The first and the most important point that I want to highlight is that it is a well established framework in implementation science, which also adds value to research findings given that it can be comparable to other contexts, to other trials, as well as projects which might be exploring similar questions. The five domains of the framework as well seem very relevant to address our key objectives of the trial. So, as a quick reminder, the five domains include reach, effectiveness, adoption, implementation, and maintenance. This framework seemed to be a prudent choice as it allowed us to answer both implementation questions, for example, how was the intervention being delivered on the ground, as well as effectiveness questions, for example, were patients even benefiting from treatment? Also, it seemed to be a more pragmatic framework to collect data through routine public sector efforts in a way that would be sustainable. Finally, it allowed us to map the mediating relationships between implementation strategies and outcomes, including clinical outcomes, in a logical and pragmatic manner. In our work, which entails a complex intervention, we needed to ensure that we collected data from many sources at different time points and in multiple ways, provided it was feasible and meaningful. As a result of using REAIM, we are now certain that our findings will be more rich and rounded as it offers perspectives from multiple moving parts of an intervention and focuses on the how and why beyond going beyond the what of the intervention. I will now hand it over to Yashi, who will walk you through the steps of adaptation of the framework and examples of how we conceptualized few dimensions of the framework.
Hi everyone, I'm Yashi and we've met in one of the lectures previously. I'm going to continue right from where Urvita left off and really deep dive into how we adopted this framework while we were conceptualizing this program from the point of view of implementation. The primary methodology that was really driving in terms of thinking about the larger program was using a theory of change. And what REAM really allowed us to do is think about our theory of change in a systematic manner. Just as you would start backwards from any theory of change map and really begin by thinking through the outcomes, we started thinking about it and brainstorming within smaller groups really about how the various dimensions of the REAIM framework would be relevant to our larger aim, either in terms of direct outcomes of the program or even indirect outcomes that may be of interest to us. The next step, really, after determining the outcomes of interest, would be around brainstorming how best you would measure it. And based on ground experience, REAIM framework really is best suited or understood when you use mixed methods, which primarily involves a combination of both quantitative and qualitative methods to understand the outcome. Um, and along with that, what is also important really is the source, which is who is the stakeholder that you're really collecting this information from. This becomes primarily important because there may be many stakeholders who would be viewing the same program from different lenses. And so you would want to triangulate your information, not just using a combination of quantitative and qualitative methods as outlined in step 2, but also from different stakeholders in order to develop a nuanced understanding of if your program was acceptable, what part of it, to whom, and what really of it was acceptable to the stakeholder that you're talking about. And was that the same when you spoke to somebody else? And this is really why thinking through step 3 becomes quite important. Um, as you think through stakeholders, you would also want to determine what are the sources of data and the different time points at which you need to interact with these stakeholders. Examples of sources of data would be, is this collected as part of routine process data in a primary healthcare and you can get this information from routine registers? Or would you need to do separate qualitative assessments or surveys in order to collect the information you need, which is directly linked to the outcome of your interest? Similarly, there could be various time points at which you would be collecting this information. Sometimes a particular dimension would be of interest to you, and you would collect that data right after training. Sometimes it would be collected iteratively throughout the duration of implementation. Sometimes you wait right till the end until the outcome quantitative assessments are done to really qualitatively understand the experience of different stakeholders. And once you really have thought through step 1 to step 4, the most important one is really to sit with the research team to ensure that you pilot it, you review it, and you iteratively revise it based on the resources you have, the context in which you're collecting this data, and how acceptable it would be to do the things that you would like to do, and whether or not it fits within your larger research timelines. I'm going to just briefly take you through 2 dimensions as examples. And this table has been strategically created to kind of give you an overview of how each dimension can have both a combination of quantitative and qualitative methods in which you could collect the data, and how it could be at different time points. And certain data points may just be relevant to one stakeholder, while a few may be relevant to multiple stakeholders, and how then triangulation of that really becomes important. So to just take an example from the table here, if you were to understand the dimension of adoption, you would quantitatively want to know all of the characteristics, specifically the social demographics of the counselors who really agreed to join the program. And you could do this at the point of training to really understand who signed up. But when you're trying to understand who actually went through the program, retention is another quantitative element that becomes really important when you're looking at adoption. However, while these numbers may only tell you part of the story, you may really also want to understand why certain people chose to continue the program and why others would not. And that would be best understood qualitatively. And so, one primary takeaway that I would like for you all to go away with is that there is no one way of prescribing how many indicators should be measured under each dimension, how many stakeholders should give you this information. The idea is that REAIM allows you the framework and flexibility, and you should almost embrace that flexibility and ensure that all of what you're thinking in terms of step 1 to step 4 is directly linked to the research aim and the question that is relevant to your program.